I can't hear you.
Okay, now can you hear me?
Yeah.
Okay, great. I was muted. It's like, okay, where's the mute button? Okay, so same thing, the Duran book for the depression, that'll be on the examination. And then please use your Dunphy book for substance abuse for the exam. Content on the exam is going to be including aspects that came from last semester because they automatically tie into the content that we're discussing today. So anxiety, what is it? How would you treat anxiety? There'll be major depression, generalized depression, identifying PTSD. So you may get a question that asks, give you a patient scenario, and they're going to ask you what you think is wrong or what your primary differential might be. What question might you ask to elicit what is actually happening with an individual who has PTSD? So that will be there. For schizophrenia, schizophrenia is a highly complex mental health problem. And because it is a highly complex mental health problem, as a nurse practitioner in primary care, we have to be able to identify it. So let's say it was me. And so what it would look like? And then is it something that we should treat in primary care, or is it something that we'd actually refer to? So we'll talk a little bit about that. Hey, Jefferson. Good to see you. Hi. Are you outside? Oh, you little wiener, you. Not fair. Oh, seriously. But it's good to see you. Then we're going to talk a little bit about bipolar disorders. And there's very distinct presentations for people who have bipolar disorder. Also, for bipolar on this first exam, I want you to go into the Duran book. Okay? So go into Duran and look at the symptoms that a person would present with, and then what would be the best way to begin management of that. For people who have these more highly complex mental health disorders, we can do a primary diagnosis or differential leading diagnosis of, but we do need to refer them over to a mental health expert for the actual diagnosis to occur from them. We can give it as the leading diagnosis, but it actually probably will actually come from them that, yep, this is in fact that. And the reason behind that is that that's not our specialty. But we understand the patterns that a person presents with that could have this. Does that make sense?
Mm-hmm.
So that's how we'll do that. So I'm going to go ahead and pull up. Hopefully I can pull up the PowerPoints. So give me just a second. I'm going to share my screen with you in just a second, okay? And I'm going to open up the first one. So I'm opening up my PowerPoint, so hang on just a quick second while I do that. I'm going to get both of them open here real quick. I have them sitting down at the bottom. All right. One more to open. Hang on. Almost there. Okay, I'm going to go to share my screen. So you're going to see what I see. Both of these PowerPoints you have available under the Modules tab, and it is under Zoom. And so you'll see both of them there. One of them says substance abuse, and the other one talks about depression. Okay, so just so you know they're there, so you can actually write on them. And now I'm going to share my screen. Maybe I'm sharing my screen. Okay, I am. So we're doing depression first. All right. So I'm going to put this into slideshow format. Alrighty. So we're going to talk a little bit about depression. And depression is one of the most common mental health disorders that we're going to see in primary care. And it has a lot of different presentations to it, but giving you a little bit of information, it has a pretty high prevalence, almost 20%. A lot of people, when they come in, will not say that they're depressed, but what they'll present to you with are symptoms. So for instance, let's say it's me, and I'll come in and I'll say, I'm just having a lot of problems with fatigue. I'm really tired. Um, I don't feel like I can concentrate. I'm concerned that maybe I have a brain tumor. Fatigue, insomnia, and lack of ability to concentrate, those three things are key puzzle pieces that link to depression. So things that you may want to ask that patient, we'll go over in just a few minutes. People will also complain of, I have a headache, I always have discomfort in the back of my shoulders, or my back is hurting me. Every patient that comes into primary care as part of review of systems, when you do your review of systems and you're asking all the questions, this mental health piece can come under a couple different aspects. You can pull it as an individual and put it under your ROS as mental health, or you can include it as neuro as part of your neuro assessment, because mental health is a neurological disorder. If you look at that, it's chemicals that are imbalanced. And so it could be either way. But either way you do it, you do need to ask a patient, are you having any problems with depression? Do you feel like you are having difficulties, or have you been feeling depressed? You do need to ask the question. You can administer to your patient a PHQ-2 or a PHQ-9. Those are two very simple and very easy scoring elements that would help give you a score of where your patient sits on a depression scale. Very simple, very easy to do. And you can record that as part of your objective information. When you do that physical assessment, this would be part of the assessment piece. It wouldn't be a review assistance piece because it's actually an assessment, so you can put it under assessment. I have to tell you that I've seen it put in both places, and depending upon what your professional preference is and how it works best with you as the provider, put it there. Somebody's going to find it someplace, okay? So depression is a risk factor, and depression is a risk factor for suicide. And so when you identify that a person does have depression, one of the next pieces that you need to ask them is, have you thought about hurting yourself? If someone says yes, they have, then we need to explore that further. Do you have a plan? Have you thought about what you might do? Have you put together a time frame? That plan piece, though, is very, very key. So risk factors for depression, they're listed here on your screen. I want you to note what they are, but also note the third one from the bottom, a serious medical illness. This serious medical illness can range from pregnancy to somebody who's had an acute MI. And it doesn't matter what the disease process is, but if that disease process is going to change that person's quality of life or affect the quality of their life, or potentially lead to mortality, then they are at higher risk for a medical, for a depression to occur. And when they're seen, they need to have more frequent screening. So just about every single time. There is a very, very strong link between substance abuse and depression. A lot of times people are experiencing depression and they turn to the use of substances to try to numb or to escape the feelings that the depression brings forward. So depression can bring forward feelings of hopelessness and of isolation and of sadness and of being shut off from others. It can give you feelings of hopelessness, and it can affect your ego, and it can affect who you believe you are as a person. And to escape that, people will turn to substances. Now, there's a couple different things. We're going to talk about substance abuse in just a few minutes, but for looking at depression, you have to be asking the questions. If a person says, yeah, I have been feeling a little low. Yeah, I am. And the PQH9 is definitely showing depression. So you got to explore me. And you do that under your review of systems. And that would be the social history part. And ask me, do you drink alcoholic beverages? And if I say yes, take it a step further. What do you drink, and how much? Whatever you do, you need to be non-judgmental. So you're just asking a question. Well, maybe I'll drink a drink or two. What type? Wine. So like 1 or 2 glasses, a bottle, 1 or 2 bottles. Yeah. Do you drink that in an evening? Is it over a couple of days? Is it in a couple of hours? Help me understand how you drink. See where I'm going on this? But remember, you have to stay based in that I'm not judging you. I'm trying to understand what's happening to you, and how you're using the substance in your life. And you can give them the rationale on why you're asking the questions. That won't hurt. The biggest fear that people have with substance abuse is the judgment, and of we passing judgment upon them and making them feel less of a person than they already feel about themselves. Does that make sense? So because I work over at Cedar and I deal with these patients on a pretty much weekly basis, they are always on guard that we are judging them, and they shutter themselves off and they get defensive about things. It's our responsibility to make sure that whatever we feel isn't transmitted in our face or what we say. Okay? So the DSM-5 provides us with these elements of what a person could present with to help us get to the diagnosis of depression. Okay, so you need to have 5 or more symptoms present most of the day, nearly every day, for a minimum of 2 weeks. Make sure that you mark on this one. Minimum of 2 weeks, most days of the week, nearly every day. That's key. You'll see it on the exam, but you will also see it probably on your boards. Whether you're going FNP or AG, it's usually on both sets of boards. Depressed mood, that could be feelings of sadness. It could be depressed mood. Loss of interest and pleasure in most things. There's a question that's a really good question to ask. So, when was your last happy day? If they really take time, they're trying to think, well, when was that? And I'm not really sure when my last happy day was. That's a trigger right there, that there's a lot of events occurring, possibly stressful events, possibly depressive events, but that's another key into this. How are they sleeping? Are they not sleeping, or are they sleeping all the time? People will say that they just want to sleep. When you sleep, you escape the thoughts that underlie depression. So people will use sleeping as also a way to escape what is occurring that's causing the depression. Changes in appetite or weight, it can go up or down. Psychomotor retardation or agitation. Psychomotor retardation, what this is talking about is that the person is having difficulty being able to do things. Oh my God, I forgot. Where did I put that? Oh my God, I put the toaster in the refrigerator. So it's like, does a toaster belong in a refrigerator? No. That's telling you or the patient that there is a lot happening up here, and it's more than they can manage at a conscious level. Agitation, as you start to ask questions, the person may start getting very antsy. They may fidget, a lot of hand twisting. Watch the foot. Watch the foot go up and down like it's bobbing, foot bobbing. Watch to see if they start curling their hair like this. This is a mental health thing. Have you ever seen people do that where they're curling their hair and they just keep doing it? And it's like, why are you doing that? That is an unconscious movement to help them cope in the moment. And I've seen a lot of patients do that. Watch their nonverbal. Are they rocking? You see them rocking. Rocking is self-soothing to help calm agitation. So if they're doing these nonverbal pieces, you've hit on something and you've caused them to become agitated. And they're trying to control that agitation by their body movement. So those are nonverbal cues. Low energy, I'm fatigued all the time. I can't concentrate. I'm not able to do it. I need to get through this class and I just can't think. Again, depression can do that. Thoughts of worthlessness and guilt. People have a tendency when they get depressed, especially if they're using substances, to know that they're doing wrong, feel guilty about it, and do it more. And that is because there's a mental health issue going on upstairs. Again, you have to ask about the suicide and death. And then it's hard to explore what could be some of the causes of the distress or the stressors that are affecting them. Sometimes they're able to identify it, sometimes they can't. But if you have at least 5 or more of these symptoms coming up that you're talking to your patient about, they are depressed. Whether they say they're depressed or not, it doesn't matter because they're meeting the criteria to have depression. Now, this is generalized depression, okay? Major depression, which we're going to get into, looks a little bit differently and has been present for a longer period of time with more intense symptoms related to depressed mood, loss of interest, low energy, poor concentration. They do have thoughts of trying to harm themselves because they can escape that way. It's their only way out. So when we talk about mania, which is your major depression, I want you just to kind of look over this slide. It is for much longer, okay? They can go up and they can go down. So they have, periods of being really elevated in their emotion and their activity. And then they slide backwards and they're like a vegetable. They want to interact with no one or nothing. It's been there for at least 1 week, present most days of the week, nearly every single day. It looks kind of the same, but notice what's missing. The 2-week mark is missing. And a person typically has depression and then it evolves into the deeper depression as the disease process progresses. There are 3 or more of the following symptoms must be present, okay, for of irritable mood. So inflated self-esteem, decreased need for sleep, so this is the hyperactivity, very talkative, especially under pressure, flight of ideas, subject experience that thoughts are racing, and they know that it's like my brain just doesn't stop. It's like I can cure the world. Distractibility, they're easily distracted, so they can't stay focused on a project. They keep going off track. And a lot of times they'll come in.
Major depression or bipolar?
Mania is actually bipolar. So mania is bipolar disorder. It is, okay? Good question, Galen. So the distractibility, sometimes they'll come in and they'll come into the office because they're close to being fired from their jobs because they can't concentrate. And as you go through your depression scale, you're seeing a whole bunch of things, but when you get to the sleep part, they may say to you, well, actually, I only sleep about 2 to 3 hours a night, and I get a lot of things done. See, I get a lot of things done. I sleep 2 to 3 hours a night. Okay, now we're coming out of depression and we're coming into, could they be bipolar? Okay. So you have to ask the depression questions, and if they're not all fitting, are they more bipolar than they are depression? And that excitability, lack of sleep, I have so much I need to get done, but the flight of ideas and superactivity, that is very classic of bipolar and not classic of depression. So as you read on down, these individuals also may love absolutely to shop. They may have shopping bills and credit card bills that are like through the roof, and they're like shopaholics. So it's one of the ways for them to stay active and do things. Okay, gambling is a form of bipolar disorder. Okay, and then when they're on their highs, they're normally, it isn't an issue, but when they're in their lows, and now it becomes the issue, and they could harm themselves or harm another person. They may slip into a significant depressive state. And here's on that low of the bipolar that you see the depression come through. And it's that part that we need to be more cognizant of, and we need to ask the person when they come in, how are you doing with your depression? Oh, I'm okay. You know, I'm bipolar. And I haven't had a lot of problems with that part of it, but I've been having a lot of issues with, I can't get my brain to stop racing. So they'll either be up or they'll be down. The medications we give them help to even them out. So they're not too high, not too low, but give them that middle ground to work off of. And that's where we try to work with our medications. So for the treatment of depression and bipolar, we have to always screen for the mania before we treat depression. Okay, always screen for it. So you're going to look for those 4 pieces. I'll go back. So hang on, I'm going to go backwards to the previous screen. So you need to screen for 3 or more of the following: inflated the self-esteem, decreased need for sleep, talkative with pressure, flight of ideas, distractibility, increase in goal-directed activity. You have to screen for these, okay, as you're working to see, do they have depression or are they bipolar? So screen for those first. If you're not getting those being positive answers, now you go down more that depression track. So for the antidepressive medications for just generalized depression, for that, we're typically going to be using our SSRIs, our selective serotonin reuptake inhibitors. And there's a whole category of those. Your Duran book does a really nice job of explaining them out and telling you which medication works best for which population base. So I'm not going to review that with you guys here, but I want you to go into the Duran book and just review that. Make sure you review that prior to your exam. Psychotherapy. You guys, I need to go on hold, okay? So I'm going to mute. Thank you guys. That was one of the doctor's offices. I'm having a real heck of a time getting my husband in for follow-up from his hospitalization, and it's very stressful. So that was one of them calling me back because I've been pushing the boundaries and trying to get them to help him because he is so sick. So thank you. Carrying on. All right. So go into your Duran book, and I want you guys to look at depression treatment. The SSRIs are where you're going to start. Okay. And then I want you to go to the bipolar section and look at the bipolar section and look at how you might initiate treatment in primary care, but then you'll probably transfer that over to a psych mental health expert. But be aware, once that person is managed and they're good to go, they will come back into your practice for you to manage. If they have episodes of mania occurring, you may have to transfer them back to psych mental health for further assistance, but they can be very well managed in primary care. Part of the treatment process with depression and with bipolar disorder, especially at the depressive end, is we have to do a combination of our clinical behavioral treatment where they're in therapy as well as medication. So it is a combination of both. You will encounter patients that adamantly refuse to go ahead and do counseling, and that is their right. You can't force them into counseling, but you can encourage them to. A lot of times, there may be abuse occurring, whether it's sexual abuse, physical abuse, verbal abuse. Something is happening that they don't want brought forward in counseling because it's too painful or because they're not able to cope with it at a conscious level, which is actually what's mediating their depression. Does that make sense? So as a nurse practitioner, you can explore that, but watch for those behaviors I was telling you about, the twirling of the hair, the hand movement, the fidgeting of the legs. You've hit something. You've hit a core. I've had patients who I've asked about, have you had experienced any sexual abuse? And they literally got up out of the chair, pacing, hitting their hands. Why are you asking that question? What's this about? And it's like, it's nothing more than a question. And then it gets heated, and then they start accusing you of things, and it's like, stay based, stay focused, stay based. Don't go down the route of you going defensive. Stay based. It's a question that I need to ask. It is nothing more than that. If you choose not to answer it, I completely understand. You don't have to answer it, but it's one that I have to ask. And stay calm with it, okay? And move on to the next question. If they refuse to ask, just move to another question. Their agitation will calm down. If you escalate, they're going to escalate. So stay very calm, all right? If you're dealing with somebody that's in a manic phase and you feel at risk, whatever you do, don't ever put yourself in a position where you are not able to get out of the room that you're in and you are trapped. So when I interview these patients, I interview so that I have the ability to get to the door or open the door to call for help. So I'm not with the patient to the door and me to the wall of the room. Does that make sense? It's just a safety thing, but you need to be aware that when you have patients that are labile emotionally, they could potentially strike out at you. And I have been hit. I've had my jaw fractured by a patient striking me. I wasn't aware that they were manic at that time. I soon figured it out. So just be aware of that. When you're talking to your patients about medications, make sure you ask about their family history and anybody in their family who has depression. And you can say any more of a more complex mental health disorder that they could potentially have. Ask those questions. And the reason you want to understand that is because there is a very strong genetic linkage with depression and bipolar disorders and schizophrenia, very strong genetic linkage. There's also a strong genetic linkage for medications. So let's say it was my mom and I'm your patient and I say to you, yeah, my mom had depression. How did she do? And what kind of treatment did she have? Well, she was on one of those SS drugs and it didn't work at all for her at all. It actually made her worse. And they wound up having to change her. There's a key right there for you that this patient may also have problems with an SSRI. You could start them on the SSRI, but you need to bring them back sooner, like bring them back in about 2 weeks instead of 3 weeks, and see how they're doing. Even though it takes about 3 to 4 weeks for the SSRI to work, they should still be having some improvement, but if they're not having any at all, it may not be the right category of drugs for them. You may have to move to a different category of medications to help them. So the next category that we have is our SNRIs. And I've got them all listed here for you underneath their generic names. And those ratios that I'm showing you, it's the SSRI product, so it's a 10-to-1 ratio of the serotonin product versus the norepi reuptake inhibitor product. So that's their ratio of concentration of drug. The bupropion, norepinephrine, and the mirtazapine, these are two medications that I personally do not prescribe a lot in my practice. They're more of a complex mental health drug, and I see my patients coming back to me with them after they've been to a mental health expert, and then I do the maintenance of them. Most of the side effects we're going to see from the medications related to the medications we use to treat bipolar disorders and depression are GI. So there's nausea and a lot of looser stools. Some of the categories of SSRIs really cause there to be quite a bit of weight gain in people. The citalopram is one medication that I know for sure can cause people to gain 5 to 8 pounds of weight. Prozac, not so much. Paxil, not so much, but Paxil has really high sedation to it. You can see improvements in about 1 to 2 weeks, but this is genetically based in how that patient metabolizes the drug and then how it is absorbed across the blood-brain barrier and gets upstairs into the cells and changes the synapse work. You can titrate them up at 4 to 6 weeks. They tell us not to try to go sooner than that because we need to let the drug's full effects take place, but also let the half-lives build for that to occur. Our goal is to get the person to remission or reduction of symptoms. And that can happen in like 6 months. It can happen in 3 months. And then we want them to be symptom-free for about a year. So at that year level, we can reevaluate the patient, and at that reevaluation determine if it's depression, not bipolar. For depression, do they need to continue on the medication? If the person is bipolar, we still want to make sure that they stay asymptomatic or in control of their symptoms, and that we have them well managed on the medications that they're on. For a person that's bipolar, we would never discontinue their medications. Their mental health disorder is a chronic disorder, and it's not going to go away. It will be with them for the rest of their life. After a person experiences 3 episodes of depression, so I had depression and I got over it on my own, no drugs. Second episode, I had to come to you, the provider, and I had to get medication. There's episode number 2, and I was on it for 6 months, and then I was good for a year and you took me off. And then I had to come back 9 months later because it happened again and you put me on antidepressants again. That's 3 episodes. Now I probably will need lifelong maintenance. So you need to titrate me up to get me managed, to get my symptoms controlled. And then once you do that, you have me come back at 3 months, have me come back at 6 months, and then the year marker. And then if I'm good, and let's say you put me on a fairly high dose, you could bring me down one level, or let's say I was on 60, you could bring me down to 20 or 40, and you can slowly bring me down and see how I do. And then that would be my maintenance dose, and then it's going to be lifelong treatment. Okay. When and how to taper off medications, the person usually directs that when you talk to them and you have them back for reevaluation. The Duran book is a really nice drug of helping you understand when it's appropriate to try the tapers and when it's not. If the patient is still experiencing symptoms, you don't taper. You can taper up, but not taper off. If a person has been, and this is depression, if a person has been asymptomatic for over a year and they're on, let's say 40 milligrams, taper them down for 20, have them come back and see you in like a month to 2 months. How are their symptoms? Taper them down to 10, have them come back, and then have them taper down to nothing. And how you would do that is they would take a 10 milligrams for the one day, and then skip a day, 10 milligrams, skip a day, 10 milligrams, skip a day. Then the next week, cut the pill in half, 5 milligrams, skip a day, 5 milligrams, skip a day, 5 milligrams, skip a day. Then it's take the dose, skip 2 days, take the dose, skip 2 days. See how I'm doing it? It's a slow taper down. If you don't, some individuals, we don't know how they actually do this metabolism, but they metabolize it very quickly and the reduction of it comes down very fast. And they can crash, and that could put them at risk for self-harm. So we don't want that to happen. And then as we're tapering them off, we want to make sure that they're doing those homeopathic things that we talked about in our health promotions course. So exercise is really, really important. Exercise at least 3 times a week for 30 to 60 minutes helps to actually homeopathically raise serotonin in my brain without a drug. So as you're tapering me down and I'm exercising, I literally can hit that beautiful homeostatic mark and not even feel that I'm not getting anything. Relaxation, doing yoga, Pilates, music, walking. When we did that intro for class this week, you guys really show great ways of self-care for helping you guys de-stress and connect. All of those are elements that a patient can do and you can share with them. So does this make sense? Are you good on that one? Okay, so we're done with that one. Now I got to bring up the next one, which I think is substance abuse. Okay, so substance abuse is next, and this one is a little bit more complex. So with substance abuse, you guys are doing your opioid training this week, so you will get a lot of this repeated. So screening tests, you have to screen. It can be very brief. I know that some of those were explained to you when you did your opioid training. Substance abuse is not a diagnosis, all right? It means that you need to follow up on what is occurring with your patient. Men 65 and under, 5 or more drinks a week or 14 in a week, this is a substance abuse. Women and men over 65, 4 or more drinks a day or 12 in a week, that is an indication that there is substance abuse occurring. So these are just kind of minimal parameters to look for. Now, this is about alcohol. When you start asking a person about drug use, it's how frequently are you using the drug? What type of drug are you using? Are you using heroin? Are you using PCP? Are you using tar products? Are you mixing medications? Are you using methamphetamines? Marijuana is a drug, and it is a substance that is abused. And though it is legal in this state and it is used for recreation, it is still a drug that has the potential for abuse, because if a person doesn't have a medical need for it, then it is a substance of abuse. Just like alcohol, I drink it when I go out to a bar with friends, but if I'm drinking it in my home and I'm drinking 6 bottles a night, it no longer is recreation. It now is a substance of abuse. Does that make sense? And you do have to screen for that. So when you're doing your assessment, you need to be asking what type of drug they're using. The alcohol, it would be what type of alcoholic product that they're using, how frequently, how much. If it's a drug, what is the route of the medication? Are they smoking it? Are they shooting it? Are they vaporizing it? How are they using the medication? History prior to substance use disorder. So when did you first start drinking? When did you first start using this? What was occurring around you? Have you ever needed treatment for alcohol use or for substance use? You'd be surprised how many people have actually been in treatment. When you have people that you know from asking these questions have substance abuse, 98% of the time there is a mental health disorder that is coinciding along with it that you need to assess for. Depression, bipolar, and anxiety are your number ones. If your person is a military person, you need to ask them about PTSD. There's a lot of anger with PTSD, a lot of drinking disorders. Eating disorders and the schizophrenia, not so much. Personality disorders, not so much. But higher risk depression, bipolar, anxiety, and PTSD military. Make sense? So you have to screen for those. Family history is strong, especially with substance abuse. In your family, was there anybody that had any drinking problems? My grandpa. Well, my dad used to go out back all the time, find him with 6-pack alcohol on the tractor all the time. Yep, that's where I had my first beer, was on the tractor. Boy, that combine sure was good to drive. This is the kind of conversations that I get at Cedar. This is when they sit down and start doing this is what they give me. In that family history, if their parents or grandparents had an alcoholic history, there's a strong probability that this is a genetic disorder. Cannabis, if it's being used in their family or was used by their parents, there's a strong probability that it's being used by a child patient or an adult patient that has a parent that does it. Opioids, people who typically use cannabinoids have used opioids, and they usually are not prescribed for them. They buy them on the street, or they buy them off of a friend, or they've stolen them from a grandparent or a parent. So you need to ask all of these. My mama has chronic pain. She takes a lot of drugs. What kind of drugs? Oh, those oxys and things like that. And she's got that patch thing that you put on. Yeah, I've used one of those. She didn't know about that though, but I used one. So they will share with you. If you keep your judgment down, you will get more than you ever bargained for. But you need to find out about that family history because alcohol, cocaine, cannabis, and opioids all have a strong family link backwards. Social history is huge. And in the social history is where you're going to find out about relationships. You'll find out about they're not able to keep a job. You'll find out that they have a lot of stress in their life and they have elements that are occurring. You will find out about if they've had abuse in their lives, and you need to ask about abuse. So it's physical abuse, verbal abuse, spousal abuse, sexual abuse. Those questions are hard to ask, but you have to ask them. If this person identifies, yes, these are occurring, now you have the probability of why they're using substances the way they are because they're trying to escape. They are going to need mental health assistance that's above and beyond what you can do in primary care. Medical conditions that could warrant the person using substances, cardiac problems, mental health problems, of course. People who have chronic pain people are individuals that have the greatest risk for substance abuse besides those with mental health, especially your cannabis, cocaine, and opioids, because they cross the blood-brain barrier and actually stimulate the mu and kappa receptors for analgesia. Along with the physical exam, you want to do a really good skin assessment. Make sure you're looking for track marks. I had a patient recently that I was admitting, and I was doing an entire assessment on him, and he was in a gown, and I asked him if I could just take a look at his buttocks. And the reason I did was at the very top of his underwear, I was seeing what I thought were track marks. And it didn't make sense to me why I would see those on his butt. Well, when he dropped his drawers, what I found was a humongous abscess that needed I&D immediately. And it was actually dripping pus. It was humongous. And what he had been doing is he had been injecting IM cocaine that he had liquefied. Well, you can't inject cocaine. It didn't go that way. And so he actually had a multi-bacterial infection that he wound up having to be admitted for. So you really have to look closely. Look between the fingers. Make sure you're checking on the thumbs and on the outer aspect, lateral aspect of the hand. There are small veins here, and they will inject in here using an insulin syringe. So you have to really look a lot of places, okay? Look for bruising also. A lot of times the patient may come into you and they're actually in withdrawal, so they can be agitated, tachypnic, and they can be tachycardic and sweaty. And those are your cardinal symptoms of withdrawal, whether it's alcohol or it is a drug. And with both of these, alcohol and drugs, there's a greater risk of seizure. So if you would get a patient in your clinic that you believe is in withdrawal, I would encourage you to transfer them to an emergency room. You can't handle them in primary care. You need to transfer them out. Everybody needs to have a really good assessment of their mental status. So you want to document what they look like. Are they disheveled? Are they unkempt? Do they smell like urine? Do they smell like body odor? What is their behavior? What is their eye contact like? That's really important. Are they avoiding you? What is their speech pattern like? Is it very rapid? Is it slow and drawn out? Are they avoiding answering questions? Are you seeing agitation in their hand movement, twirling of the hair, rocking? Are they pacing? Do they have escalated answers to questions and then they slow down? All of this needs to be documented. Are their perceptions skewed? What is the thought process like? Do they have good insight and judgment? And then always assess for suicide ideations or homicidal ideations. You know, I really hate my dad. I hate him for doing this. You know, if I could just get at him. Are you thinking of harming your father? Oh, no, I just want to get at him. Okay, that is a homicidal ideation. Okay. A lot of times your alcoholic patients will have elevated LFTs and an elevated MCV when you do their CBC. For your patients that are drug abusing, especially cannabis, cocaine, and opioids, you can get hyperthyroid being present when you run a TSH on them. There's high risk for these individuals also to go ahead and have sexually transmitted diseases occurring that are not treated for because they have risky behaviors. So they all need to have STD screenings. You also need to do a drug screen on them and find out exactly what they've been doing. A lot of times with some of the street things that they're obtaining, they're laced and they have no idea that the cannabis that they've been smoking is actually laced with heroin. And you'll pick up heroin as well as the cannabis when you do a drug screen. And the patient has no clue, but they've had a great high, but they don't know that they've been ingesting heroin. Medical conditions that you can see with alcoholics and with people who use substance abuse are all of these that you see here. You guys are probably really familiar with the pancreatitis that occurs in these patients. You're alcoholic. As you withdraw them from the alcohol, or they're going through alcohol withdrawal, they can be very hypertensive and crisis hypertensive. That's why they need to be in a setting where they can have appropriate monitoring. Cardiac symptoms, they have the tendency to be very tachycardic. We give them clonidine for this. They can have neuropathies that occur with the drug, especially with alcohol withdrawal. They get numbness and tingling and paresthesias to their hands and their feet. We use Neurontin to treat this. Electrolyte imbalances, the most common is going to be your potassium and your sodium. For sodium, we just have them drink a lot of fluids and use Gatorade. For the potassium, we give a potassium supplement depending upon how low they are. For insomnia, they use a lot of Seroquel to treat it. There can be bone marrow suppression, so you can see anemias, and the microcytosis that we've talked about. A lot of times, these individuals will wind up in an emergency room because of a traumatic incident where they've passed out from either their drug use or their alcohol use, and they were taken there, and then they've been admitted, and they will come out, and then they need primary care to follow up with them. The DSM-5 criteria, I would ask you just to kind of review this. These are some of the questions that you would ask them, and the more questions, 2 or more of the following in the past 12 months is positive for potential for substance abuse to occur. So just be aware of what they are. And then the treatments, in order for a patient to be appropriately treated, they really should be in a drug rehab program or alcohol rehab program, whether outpatient or inpatient. Group therapy and individual therapy is occurring. For the person that's an alcoholic, antabuse has been used quite a bit. Excuse me. Naltrexone is being used, and Vivitrol. The buprenorphine, another medication that's being used for drug addiction. You need to be trained on these medications in primary care. You can't just start giving them, especially the buprenorphine. You must be certified, and you have to have that as an extra certification on your DEA. You can't just begin prescribing it. This methadone is something I would tell you not to try and do in your primary care settings. I would let that be for individuals who have this appropriate training. We don't really have that training well enough. Naltrexone and the Vivitrol, you can also get that training on how to use these medications and then use them in primary care. It is your choice if you choose to do this type of treatment in your primary care or not. It is up to you, and you'll make that decision. And that's it for this. Galen, you're the last one left. Do you have any questions?
No, I just need to finish all my reading and studying.
Okay.
Thank you.
You're welcome. Thank you for being here today for this. And for those that are going to watch this at a little later time, if you have any questions, please don't hesitate. Make sure you go ahead and just contact me if you have any questions. So thanks, you guys, and I will see you at the next Zoom meeting. Heading off, Jefferson, I'm going to put this thing up as a recording, okay? Bye, Jefferson. We're signing out. I'm going to put it up as a recording in just a few moments, okay?